Anyway, I told you that optic nerve, today's lecture, optic nerve begins at the optic disc blind spot where the fibers of the stratum opticum converge, pierces the outer layer of the retina, choroid and lamina cribrosa of sclera at the posterior part of the eyeball, 3 millimeters to the nasal side of the posterior pole. All your textbook has beautiful pictures. Please follow your textbooks and also the competency-based questions that is highlighted in your textbook. You please note at when you are revising, reading, stress, be focused and do all competency-based question and answers. During this passage through the tunics of the eye, it acquires myelin sheath. Optic nerve passes backwards and medially through posterior part of the orbital cavity and optic canal and joins with the optic chiasma in the cranial cavity. Now, intraocular part, the optic papilla or optic disc. Now, the optic nerve head, see, this is the retina, this is the choroid, this is sclera, this is sclera. Now, surface nerve, fiber layer, pre-laminar region, this is the pre-laminar region, lamina cribrosa region and retrolaminar region. You draw the diagram and just have these colors. Follow 1 or 2 colors or 3 colors. Okay. Now, intraorbital part, see, this is the ciliary muscles and to sphincter papillae, this is not supplied to the sphincter pupillae. Superior rectus, this is the optic nerve, this portion. This portion, yeah. This portion. This is the medial rectus, ocular nerve, nerve 3. Yeah. Ciliary ganglion, inferior rectus, inferior oblique muscle, sphincter pupillae. Anteriorly separated from the extraocular muscle by orbital fat. Anteriorly separated from the extraocular muscles by orbital fat. Posteriorly annulus of Zinn. Laterally ciliary ganglion, division of the third nerve, nasociliary nerve. Sympathetic plexus and abducent nerves. You must, when you are reading, you must draw pictures. Then it becomes easier understanding. It can be, you just have to don't be a Kolabhavan or Calcutta Art College student. Just draw to say and label them. If you draw and label them, don't color so much. And you will get your marks. Theory papers will be going outside. So, now you see this picture. Every book has it. Now, intracanalular part. Now, this is superior rectus muscle. This is the levator palpebral. This is trochlea here. Now, inferior oblique muscles, inferior rectus muscle, medial rectus muscle. This is ciliary ganglion. This is the oculomotor nerve and the trochlear nerve, optic nerve, This is the optic nerve here. Enters the optic canal through the optic foramen, closely related to the ophthalmic artery, which crosses nerve inferiorly from medial to lateral side in the dural sheath, then leaves the sheath at the orbital end of the canal. This is the undersurface of the brain. Here is the optic chiasma, and this is another view. This is the optic chiasma here. Supraorbital artery, the supraorbital artery, ciliary artery, and this is the optic canal, 10 millimeters to 3 millimeters, internal carotid artery. Now, intracranial part. Intracranial part. Now, you see this is sphenoid. This is pituitary gland. This is cavernous sinus. And this is temporal oculomotor artery, a nerve, trochlear nerve, abducens nerve, ophthalmic nerve, and maxillary nerve. This is draw a picture and intracranial part of the optic nerve and its relations. The very important picture now lies above the cavernous sinus. Optic chiasma is formed just above the cella and covered by pia only. This nasal cavity, sphenoidal sinus. Peculiarities of the optic nerve: not a peripheral nerve, but a prolongation of the white matter of the brain. Not a peripheral nerve, but prolongation of the white matter of the brain. This is important. Covered by 3 meninges of the brain with subdural, subarachnoid phase, so undergoes atrophy in prolonged increased pressure of the CSF. That's why any cranial injury, any headache, any loss of vision, blurred vision, and smoky, that has to be referred to your ophthalmologist. When you are attending emergencies, you please eye checkup, refer to ophthalmologist. Put a note on your bedhead ticket. And nowadays, very good ophthalmoscopes, very cheap, even very good otoscope are available. So you have a stetho, you have your hammer, you have your, when you are doing clinics in medicine, and you have your ophthalmoscope, otoscope. Small bag, put it in your apron pocket, and when you are in rounds, you please try to see. এগুলো কেউ শিখিয়ে দেবে না. No one will teach you. So, you don't wait when the lecture will be given or something. When you are getting a duty, you are doing 3 months of medicine, please carry this in 3rd year, 4th year. Whenever you are having that specific your study, see, you will see even diabetic retinopathy. You have books, you will see 4 figures. In Davidson, your any clinical methods book, beautiful pictures. You at least start learning from your 3rd or 4th year. Now, Because see, prolonged increase of CSF, myelination of the optic nerve is derived from oligodendroglea and not from Schwann cells. So devoid of endoneuron, and if damaged cannot regenerate. It cannot regenerate the optic nerve because of its the myelination of optic nerve is derived from oligodendroglea and not from Schwann cells. So devoid of endoneurium, and if damaged cannot regenerate. Pile sheath carrying blood vessels projects into the substance of the nerve, and this arrangement provides rich blood supply to the nerve. Now, meningeal sheath of the optic nerve. The intracranial part, pia mater, intracranial, canalular and intraorbital part, all three layers of the meninges. Now, dural sheath, subarachnoid and subdural spaces are continuous with that of the brain. So, the CSFs, if the intracranial pressure due to pathological conditions, it increases, then it will be reflected in the optic nerve. Now, pile network, the optic nerve supplied by axial system derived from the central retinal artery. Pile network composed by internal carotid artery, middle cerebral artery, anterior choroidal artery, posterior cerebral artery, deep optic artery. Components of the optic nerve: special somatic afferent fibers for vision, special somatic afferent fibers for vision, afferent from pupillary light reflex and accommodation reflex, a few efferent retinopetal fibers, the afferent from fibers for vision, afferent from pupillary light reflex and accommodation reflex. Now, you must have carry a torch in your clinics. So you see both the eyes. Okay. Not that the ophthalmologist will see it. You see it. Then after some 10 years experience or something, you can clinically diagnose most of these neurological manifestations that MRI or CT cannot give. Other corrections of the optic tract: in addition to lateral genicular body, fibers from optic tract also pass to suprachiasmatic nucleus of hypothalamus from controlling circadian rhythms, pretectal nucleus for control of fixation of eyes on objects of importance and for pupillary light reflex, pretectal nucleus for control of fixation of eyes on objects of importance and for pupillary light reflex. Superior colliculus for control of bilateral simultaneous movements of the two eyes. Superior colliculus for control of bilateral simultaneous movements of the two eyes. Pulvinar forms secondary visual pathway. Corpus callosum causes exchange of visual information between right and left hemispheres. Corpus callosum causes exchange of visual information between right and left hemispheres. Okay. Now, optic chiasma. The optic chiasma, uncrossed temporal fibers, crossed nasal fibers. This is crossed. This is crossed. So, uncrossed temporal fibers, crossed nasal fibers. Now, optic nerve, anterior knee of the von Wille gland, optic chiasma, optic tract. Now, posterior knee of von Wille gland, this portion. Now, superior fiber orientation through optic chiasma. Temporal fibers, the dotted lines passes through the chiasma and in the ipsilateral optic tract, nasal fibers crosses its chiasma to exit in contralateral optic tract. Optic tract winds around the upper part of the basis pedunculae and flattens out to form a small medial root and large lateral root. Winds optic nerve, optic tract winds around the upper part of basis pedunculae and flattens out to form a small medial root and large lateral root. Medial root connected with medial geniculate body and forms fibers of Gunn's commissure through optic chiasma, ventral supraoptic decussation. So, medial root connected with the medial geniculate body and forms fibers of Gunn's commissure through optic chiasma, ventral supraoptic decussation. Optic tract, macular fibers crossed and uncrossed occupy dorsolateral aspect of the optic tract. This is the macular fibers, the lower retinal fibers, upper retinal fibers, arrangement of fibers in the optic tract. The arrangement of the fibers of the optic tract. This is the macular fibers, this is the upper retinal fibers and lower retinal fibers. Now, lower peripheral fibers laterally situated. Gunn commissure. Now, you can see the optic nerve, with the cross fibers, blue. The optic tract, commissure of Gunn, pulvinar, lateral geniculate body, superior colliculus, medial geniculate body, nucleus of oculomotor nerve, nucleus of trochlear nerve, and nucleus of abducens nerve. And these all go to the cortex of the optical lobe. So, any head injury and severe head injury, then there might be loss of vision or any complications due to the injury of the portion, see from this, the anterior part of the skull. It goes in the brain in different place, even going into the different nuclei. And this is the pulvinar, the lateral geniculate body. You must know, medial geniculate body, nucleus of oculomotor nerve, nucleus of trochlear nerve, nucleus of abducens nerve. This again come into the cortex of the optical lobes. Lateral root, most of the fibers terminate in cells of lateral geniculate body for perception of vision. Most of the fibers terminate in cells of the lateral geniculate body for perception of vision. Some fibers sweep medially below pulvinar of thalamus and pretectal nucleus by superior brachium. They are concerned with pupillary light reflex and reflex for turning head and eyes to pursue a moving object. Few fibers terminate in the suprachiasmatic nucleus of the hypothalamus, forming retino-hypothalamic tract. Now, few fibers terminate in the suprachiasmatic nucleus of hypothalamus, forming retino-hypothalamic tract. These fibers are connected to pineal body and mediate influence of light and dark for circadian rhythm. Now, retino-hypothalamic pathway, the lateral geniculate body, lateral geniculate nucleus, the right retina, the optic chiasma, the left retina, and suprachiasmatic nucleus. Functional significance of optic tract. The genitocalcarian system is concerned with perception of vision and solves the question, what is it? And tactile system by reflex action turns the eyes, head and neck to follow the moving objects and answers the question where it is. ধরো তুমি কাউকে বললে এই দেখো ওখানে ওই পাখিটা উড়ে যাচ্ছে, তো তুমি ইয়ে করার পর then that tactile system by reflex action, the tactile system by reflex action turns the eyes, head and neck to follow a moving object and answers question where it is. So you can see that it is so in rhythm. As you see any object, then you perceive in milliseconds or whatever it is, you cannot measure. When your two friends are going in a motorbike, you are in the back seat, you are seeing something, and the rider is seeing, he's busy with it, seeing the road, traffic, everything. Now suddenly you say, see that. He looks into it. Or say, a flight of birds are moving. And the sun is setting. That beautiful, you are perceiving in the back seat that it is beautiful. But in this, you cannot, like say when you are looking into anyone's eyes, your emotions are being poured, I would say, and that is going into your brain, the specific nucleus and specific areas of the brain, and suddenly you express something. It might be verbal, it might be just holding him tight, but you express automatically. You don't realize that something is happening within your brain. তুমি তো বুঝতে পারছো না যেটা ব্যথা হচ্ছে বা কিছু হচ্ছে, যখন লাইট টুকলো এই যে মানে that's why I told you in my first lecture, the mind controls the brain or brain controls the mind. I have not got an answer from you. The mind controls the brain or the brain controls the mind. It's a riddle. Anyway, now submammalian vertebrates, tactile system has dual role of visual perception and visuomotor reflex. Mammals consciousness of vision by visual cortex and visual reflex by tactile system. Tactum visual recognition. Ascending visual pathway, the geniculostrate pathway from and detailed tectopulvinar pathway, motion and location. Both pathways start with the optic nerve leaving the eye. Geniculostrate pathways, the optic chiasma crossover, the selective attention, left geniculate nerve, occipital areas, 17 simple cells, 18 complex cells, 19 hypercomplex cells. Occipital areas, 17 simple cells, 18 complex cells, 19 hypercomplex areas. Temporal lobe, object identification. The temporal lobe, object identification. Now, optic chiasma crossover, superior colliculus, location mapping, occipital lobe, 18 motion, 19 complex motions, temporal lobe, combined visual information. You please see your textbook. Now, retina geniculate striate system. Retina geniculate striate system, visual field of left eye and visual field of the right eye. Foveal area of both visual field. Now, projection on the left retina. This is the optic nerves, the temporal, hemiretina, nasal hemiretina, projection on right retina. Now, optic chiasma, the optic tract, lateral geniculate nuclei, primary visual cortex. Input to the primary visual cortex to the medial surface of the left hemisphere. Input to the primary visual cortex on the medial surface of the right hemisphere. Visual field and retina, monocular visual field, bounded space of environment seen by one eye when that eye is fixed on a stationary point. Monocular visual field, bounded space of environment seen by one eye when that eye is fixed on a stationary point. Binocular field of vision, since normally we see with both eyes, there is almost a complete overlapping of monocular fields of both eyes. Monocular crescent. Most lateral peripheral areas of the visual field are seen by one eye only. Most lateral peripheral areas of the visual field are seen by one eye only. That's why when you are viewing your histology slides, I tell you every time it's a binocular microscope, then you have to see with both eyes. With both eyes, if you see it, you see this in the monocular crescent, most lateral peripheral areas of the visual field are seen by one eye only. Binocular field of vision, since normally we see with both eyes, there is almost a complete overlapping of monocular fields of the eyes. That's why you just don't take your specs and like this, don't do this. Retinal quadrants is divided by into four. Retina, as you would see it through the ophthalmic scope and patient's pupil. Temporal hemisphere, nasal hemisphere. The blind spot in the visual field correspond to the location of the optic nerve head on the nasal side of the retina. The blind spot you will see. Now, doing an ophthalmoscopic examination, the blind spot in the visual field corresponds to the location of the optic nerve head on the nasal side of the retina. Retina, as you would see through ophthalmoscope and patient's pupil. Now, this is the temporal hemiretina, nasal hemiretina, upper temporal quadrant, upper UTG, lower temporal quadrant, LTG, your upper nasal quadrant, this, and lower nasal quadrant. Now, the nasal part, upper and lower nasal quadrant. The temporal part, upper and lower your temporal quadrant. Visual field and retina, the nasal half of field of vision of each eye is smaller than its temporal half because of the shadow of nose. The nasal half of field of vision of each eye is smaller than its temporal half because of the shadow of the nose. Right half of field of vision of an eye is projected to the left half of retina, left hemiretina, and left visual field to the right hemiretina. Now, field of vision of an eye or retina may be subdivided into quadrants by two meridional lines, horizontal and vertical, and intersecting in middle of the macula, The previous picture I showed you. Thus, upper nasal quadrant of field of vision is projected to the lower temporal quadrant of the retina. This is the iris, pupil, and cornea in white. This is the lens, this is the fovea, blind spot is here. So this is the nose you are seeing. The two eyeballs. Now visual field, retina, optic nerve, optic chiasma, optic tract, and lateral nucleus of the thalamus, optic radiation, visual cortex. It's a beautiful picture. You practice and you will get results. Now, visual fields. the monocular crescent of the left eye, the binocular visual field, monocular crescent of the right eye, retina of left eye, retina of right eye. Dotted outline is monocular field of left vision, dotted monocular. Solid outline monocular field of right eye. This is right eye. The images of an object visual field is inverted and reversed right to the left on the retina. Temporal field of left eye, red and purple, is seen by the nasal retina of the left eye, and nasal field of the left eye, green and yellow, is seen by the temporal retina of the left eye. Superior field of the left eye, red and green. The superior field of the left eye, red and green, is seen by the inferior retina of the left eye. Inferior field of the left eye, purple and yellow, is seen by the superior retina in the left eye. Similar, the images is inverted, reversed on the right eye. Note, to avoid confusion and avoid by convention, central representation, visual deficits, etc. will be described in terms of visual fields and not referred retinal quadrant. So visual fields, it will be referred by visual fields. Eye examination. Eye examination, eyes are the window to the brain. Visual acuity, eye, nerve 2, beyond in the visual pathway. Visual field, central and peripheral vision, retina to the cortex. Ocular motility, nerves 3, 4, 6. Reflexes, pupillary right reflex, CN2 and CN3. Accommodation near reflex. Corneal reflex CN5 and C7. Retina including optic disc, increased intracranial pressure, status of blood vessels, reflecting hypertension, diabetes, etc. This is important. Visual pathways, since it is precisely organized and extends from the rostral to the caudal aspect of the hemispheres, lesions along the pathways produce specific deficits that can aid in localizing the lesion. In the clinical examination, you can localize. You don't wait for a MRI report to come after 2 days or 3 days. You order for an MRI or you order for your best is USG. And also the OCT imaging of eye. That's very important. OCTs are in every good eye center. It's an office procedure. Now, lesion of the visual pathways. Plotting visual field loss usually points to the approximate location of the causative lesion in the visual pathways. Lesions central to the retina are usually attributed to the optic nerve lesions. Lesions of the optic chiasma involving crosses nerve fibers produce bilateral fields in case of a pituitary adenoma, that is bitemporal hemianopia. If there is a pituitary tumor adenoma, then there's hemianopia. Now, lesions of the optic tract are rare but distinctive. The tract contains contralateral, nasal and ipsilateral temporal retinal fibers, and damage will cause homonymous hemianopia, hemipanopia with substantial incongruity, dissimilar effects on both different fields. Now, lesion of the lateral geniculate body causes quadratic visual field defects, pie in the sky defect. Lesion of the occipital lobe also shows quadratic field defects due to the anatomic arrangement. However, in most cases, macular sparing. Bilateral destruction, bilateral destruction of the occipital lobe causes subjective blindness. Bilateral destruction of the occipital lobe causes subjective blindness. Now, these are the definitions you see in the book. Fields not retinal quadration, normal visual fields. Blindness of the right eye, blindness of the right and contralateral left quadripenia, bitemporal hemianopia. Actually, I have not brought my specs. Getting blurred vision. Now, strabismus, diplopia, amblyopia, scotoma, quadrantopia, and hemianopia, heterogeneous defect, homogeneous defect, congruous defect, congenious defects, altitude and defect. Lesion of the visual pathways. Lesions of the optic nerve characterized by marked loss of vision, complete blindness on the affected side, associated with abolition of direct light reflex on the ipsilateral side and consensual on the contralateral side. Causes optic atrophy, indirect optic neuropathy, acute optic neuritis, traumatic avulsion of the optic nerve, example, right optic nerve involvement. Lesion through the proximal part of the optic nerve, ipsilateral blindness, contralateral hemianopia, abolition of direct right reflex on the affected side, the consensual light reflex on contralateral side, near reflex intact, right optic nerve involvement in the proximal part. So, by clinical examination, most of these diagnoses can be made. Now, anterior chiasmal affects the ipsilateral optic nerve fibers, the contralateral infranasal fibers, ipsilateral optic neuropathy manifested as central scotoma and a defect including the contralateral supratemporal field, also known as junctional scotoma. Abolition of direct light reflex on affected side, consensual light reflex on contralateral side, near reflex intact. Central lesion of chiasma sagittal characterized by bitemporal hemianopia, bitemporal hemianopic paralysis of pupillary reflex usually lead to partial descending optic atrophy. Causes suprasellar aneurysm, tumors of pituitary gland, craniopharyngioma, supercellular meningioma and glioma of the third ventricle dilatation due to obstructive hydrocephalus, chronic chiasmal arachnoiditis. Lateral chiasmal lesion characterized by binasal hemianopia, binasal hemianopic paralysis of pupillary reflex usually head to partial descending of optic atrophy. Distension of third ventricle causes pressure on each side of the optic chiasma. Atheroma of carotid and posterior communicating artery. Posterior chiasmal syndrome. Macular fibers cross more posteriorly in the chiasma. Paracentral bitemporal field loss. Posterior lesion may also involve the optic tract, cause a contralateral homonymous hemianopia. Lesions of the optic tract characterized by incongruous homonymous hemianopia with hemianopic pupillary reaction, Rinker's reaction. This lesion usually lead to partial descending optic atrophy and may associated with cervical third nerve paralysis and ipsilateral hemiplegia, syphilitic meningitis, gamma, tuberculosis, tumor of the optic thalamus, aneurysm of superior cerebellar posterior cerebellar arteries. Lesions of lateral geniculate body leads to homonymous hemianopia with sparing of pupillary reflex and may end in partial optic atrophy. Lesions of optic radiation causes vascular occlusion, primary and secondary tumors, trauma characterized by total optic radiation involvement and complete homonymous, hemianopia, sometimes sparing macula. Lesions of the visual cortex, pupillary light reflex is normal. Optic atrophy does not occur following visual cortex lesion. Congruous, homonymous, hemianopia, sparing macula. Congruous, hemianopia, macular defect. Occlusion of posterior cerebral artery, supplying anterior part of the occipital cortex. Head injury, gunshot injury, leading to lesions of tip of occipital cortex. Lesions of the parietal lobe involving superior fibers of the optic radiation. Inferior quadratic hemianopia on the floor. Lesions of the temporal lobe involving inferior fibers of the optic radiation. Superior quadratic hemorrhage fire on the roof. Accommodation of the lens for near vision. The ciliary muscles contract. Accommodation of the lens for near vision. Ciliary muscles contract. Ciliary body pulls forward and inward. Tension and substantial ligaments of the lens is decreased. Lens becomes thicker, rounder due to its elasticity. Pupil constrict. Accommodation of the lens for far vision. Ciliary muscle relaxes, ciliary body returns to its resting state, backwards and outwards. Tension on suspensory ligaments of the lens is increased. Lens becomes thinner, flatter due to its elasticity. Pupils dilate. Visual reflexes, light reflex or pupillary reflex, when light is shown to one eye, normally the pupil both eyes constrict. Direct light reflex, the constriction of the pupils upon which light is shown is called direct light reflex. Indirect or consensual, the constriction of pupil on the other eye even though no light is shown. Now light stimulus, optic nerve, optic tract, pretectal nucleus. Then Edinger vestral nucleus, oculomotor nerve, ciliary ganglion, short ciliary nerve, sphincter pupil. This is the pathway. Pretectal nucleus and Edinger vestral nucleus. Oculomotor nerve, ciliary ganglion, sphincter papillae. Accommodation reflex. When the eyes are focused from a distance to near objects, three reactions take place. One, constriction of pupils, thickening of the lens due to contraction of the ciliary muscles, convergence of both eyeballs. These three reactions together will constitute accommodation or near reflex. Now you see the visual information, optic pathways, primary visual area, cortex area is 17, superior longitudinal fasciculus, frontal eye field area 8, corticular nuclear fibers, oculomotor nucleus, both sides. Third nerve, muscles of accommodation are medial rectus, ciliary muscles, sphincter pupillae. Now, a short note, muscles of accommodation. So, this muscles of accommodation is medial rectus, ciliary muscles, sphincter, and supplied by third nerve. Pupillary dilatation, mydriasis. Now, Horner's syndrome, you at least know the names. The pupillary constriction, ptosis, flushed or dry skin, loss of sympathetics, lesion can be in CNS or PNS, deficient ipsilateral to lesion. Pupillary dilatation, mydriasis, Horner's syndrome, pupillary constriction, meiosis, the pupillary light reflex, the apparent limb, the bulb here. Now, apparent limb, optic nerve, now efferent limb, oculomotor nerve, postganglionic, preganglionic fibers. Direct reflex, consensual reflex. Reflex abolished if afferent or efferent are damaged. Damaged right optic nerve. You will see. Damaged right oculomotor nerve. This will be position of the pupil. Different defects. You can see the dilatation, damaged right ocular nerve, damaged right optic nerve. Abnormalities of the pupillary reaction, amneurotic light reflex, absence of direct light reflex on affected side, absence of consensual light reflex on the normal side. Indicates lesion of the optic nerve or retina on the affected side, leading to complete blindness. In diffuse illumination, both pupils are of equal size. Different pathways, absence of both direct and consensual reflex on affected side and presence of both on the normal side. Near reflex is also absent on the affected side. Causes effect of parasympathetic drugs, sympatholytic drugs, internal ophthalmoplegia, third nerve paralysis. Marcus Gunn pupil. It is the paradoxal response of light in the presence of relative afferent pathways. It is tested by swinging flashlight test. It is the earliest indication of optic nerve disease even in the presence of normal visual activity. See, this is Marcus Gunn pupil. It is the paradoxical response to light to the presence of relative afferent pathways. It is tested by swinging the flashlight test. It is earliest indication of optic nerve disease even in the presence of normal visual activity. Rings, hemianopia pupil indicates lesion of optic tract. Light reflex, ipsilateral direct and contralateral consensual, is absent when light is thrown on the temporal half of the retina on the affected side and nasal half of the opposite side, while it is present when light is thrown on the nasal half of the affected side, the temporal half of the opposite side. You just know the name and go home and study. That's Argyll Robertson pupil, ARP. Here the pupil is slightly small in size and reaction to near reflex is present, but light reflex is absent. That is, there is light near dissociation. Both pupils are involved and dilate poorly with mydriatics. It is usually caused by lesion, usually neurosyphilis in the region of the tectum. Addy's tonic pupil. Reaction of light is absent and near reflex is very slow and tonic. The affected pupil is large. Anoscoria. It is caused by postganglionic parasympathetic pupilomotor damage. It is usually unilateral associated with absent knee jerk and occurs more often in young movement.